Hello, everyone. Welcome to today's live broadcast, Newly Updated Guidelines for the Diagnosis of Multiple Myeloma. I am Judy O'Rourke, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by Binding Site. Binding Site is a specialist protein company committed to the research, development, manufacture, and distribution of innovative immunodiagnostic assays for the global laboratory market. For more information, please visit thebindingsite.com. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem through the green Q&A button lower left. I would now like to introduce today's speaker, Dr. Ola Landgren. Dr. Ola Landgren is the Chief of the Myeloma Service in the Division of Hematologic Oncology at Memorial Sloan Kettering Cancer Center and Professor of Medicine at Weill Cornell Medical College. Previously, Dr. Landgren was the Chief of the Multiple Myeloma Section at the National Cancer Institute, NCI, in the Center for Cancer Research. Dr. Landgren received his MD and PhD at the Karolinska Institute in Stockholm, Sweden. I will now turn it over to Dr. Landgren for his presentation.
Thank you very much for those kind introductory words. It's really a great pleasure for me to be able to give this presentation. The title of my topic today is Newly Updated International Myeloma Working Group Criteria for the Diagnosis of Multiple Myeloma, the Importance of Biomarkers in Early Stage Disease. I think this is a very hot topic, and I think it carries a lot of promise for patients around the world. It's very important for clinicians to be aware of these new updated criteria because myeloma has not changed from being a disease defined by symptoms to a disease defined by biomarkers. And I will go through this in more detail. Before I go into my presentation, I would like to provide you with this disclaimer. This is part of this educational program. And as you can read, in the US, the free light chains, they're intended for quantification of kappa and lambda free light chains in serum, and there are additional text that's part of this disclaimer. As a background for my presentation, I also want to put this whole topic in context. In 2015, there are about 23,000 patients diagnosed with multiple myeloma. The number is increasing over time, and this is because of an aging population. At this very moment, there are probably around 80 to a little bit more, 85,000 people living with myeloma, and that number is also going up as more people are being diagnosed and people live longer. African Americans have about a 2 times higher risk of developing myeloma, and they have about 5 to 10 years earlier age of onset. The average age of myeloma patients at the age of diagnosis is around 70 years. But of course, people can be younger and older than the average. Less than 5% are below the age of 40. We published in 2009 a study showing the link between precursor disease and multiple myeloma. In brief, we had access to more than 77,000 people's blood, and they were healthy at the time. They had no cancer development, and they were followed over time and donated blood every year for a total of 6 years. Over time, they were followed also for cancer development. There were a total of 71 individuals who did develop multiple myeloma, and we went back to the freezers and looked whether there was evidence of protein abnormalities. We found that in every patient there was evidence of MGUS and smaller myeloma. So this study is the definitive study linking the two entities, the precursor disease with the cancer. Importantly, from a clinical point of view, I'm not saying that patients with MGUS are going to go to myeloma. I'm saying that myeloma patients had MGUS. But as you know, most patients with MGUS will not progress into myeloma. So that's important to also keep in mind. Now going into the very topic of today, which is the updated International Myeloma Working Group criteria for the diagnosis of myeloma. I already told you that this is an important piece of work that was released only 3 months ago in Lancet Oncology, and there were authors around the world working on this for a long time. And Vincent Rajkumar from the Mayo Clinic is the lead author. He did a brilliant job putting all this work together in one paper. I do think it's fair to say that these new criteria is a small step for man, but a giant leap for mankind. And the reason I say that, as I already told you, myeloma with this study changed from being a disease defined by symptoms to a disease defined by biomarkers. So you don't have to develop fractures or kidney failure before your doctor starts you on therapy. You actually could have lab abnormalities that would make the doctor make decision to start therapy. So these new criteria, they define multiple myeloma requiring therapy based on these new biomarkers. And this is important. Before I jump into the criteria, which will be on the next and the following slides, I just also want to outline and distinguish multiple myeloma in relation to precursor disease. So this is from the last version, before the updated version, from the 2003 version published by the International Myeloma Working Group, showing the three entities: monoclonal gammopathy of undetermined significance, smoldering multiple myeloma, and multiple myeloma. The first category, monoclonal gammopathy of undetermined significance, as you can see on this slide, is still defined the same way, is less than 10% abnormal plasma cells in the bone marrow and less than 3 grams per deciliter M protein in serum. And the patient is not allowed to have evidence of multiple myeloma. That's what we're going to spend time talking about, how that has not changed. The difference between this precursor state and the smoldering multiple myeloma precursor state is the cutoffs. Smoldering myeloma is defined as 10 or more % plasma cells in the bone marrow, and the M spike 3 grams per deciliter. Still no myeloma criteria. So in order to be smoldering, the patient can have either more than 10% plasma cells or more than 3 grams, or both of these two factors. So one of them is enough. And myeloma has been defined by the old CRAB criteria. And here is where the change is. In this new updated version, and again, I'm going to go into full detail on the following slides, there are now 3 what we call myeloma defining events. And they are plasma cell burden in the bone marrow, they include light chains in the blood, and they also include focal lesions that could even involve the bone marrow, the bone or the bone marrow. And I'm going to go into these details now. Okay, so here are now the new criteria for myeloma. We still have the CRAB criteria, and then we have the myeloma defining events. And there is no acronym for this, so for the purpose of trying to be simple here, I put in number 1, 2, and 3. And I'm going to go over these myeloma defining events one at a time here. So the first one is the bone marrow plasma cell burden of the patient. And as you can see, if the patient has 60% or greater, that would be the first criteria. This originates from a study that was actually a reanalysis of the Mayo Clinic retrospective smoldering myeloma study, including 276 patients. They found that 6 of their patients had 60% or higher plasma cell bone marrow infiltration. And when they looked at the time from having this diagnosis of smoldering to the time of multiple myeloma, as you can see, the average time was 7.7 months for these patients. And 5 of the 6 patients had progressed or died within 14 months. They then went to validate it in a larger series, including more than 600 patients. And they found the same thing virtually, as you can see in the middle paragraph, that there were 21 out of these 651 patients who had 60% or greater with a short time to progression. And after that, there was also a study carried out in Greece by Kastridis et al., where they showed that the median time to progression for their patients with more than 60% plasma cells was 15 months. So we now have the first 2 findings here in one paper, and then the Greek study have 2 studies showing the same thing. So that led to the inclusion of these criteria as part of the new myeloma diagnosis. It should be emphasized that when you determine the plasma cell infiltration in the bone marrow, as you're well aware, you can do it in different ways, and the key ways would be to do the core biopsy or the aspirate. And it is not reliable to run the plasma cell count in the flow cytometry machine, because there will always be contamination by blood, and also the machine will lyse the cells. So that number will always be too low. It's going to be false too low. So the ultimate test would be to do the core biopsy and stain for CD138, not H&E, but to 138. That would give a very fair estimate. And the second best would be to use the aspirate and to count it manually from that. But that probably would be at least a factor of 2 lower sometimes. The flow machine can be up to 100 or even more fold too low. If there is a discrepancy between the two methods, the higher value is true value, and that's also in the guidelines. Now going to the second one, and here is the blood-based test of the serum-free light chains. And the criteria is that if the light chain ratio is 100 or greater, the patient has multiple myeloma requiring therapy. There is an extra detail here. The one that is the elevated one, the one we call the involved, that has to be greater than 10 milligrams per deciliter, or if you use the unit, 100 milligrams per liter. And this, again, came from a study that was developed at the Mayo Clinic. They had 586 patients with smoldering myeloma, and they had an 80% probability to progress to myeloma. And they did a lot of analysis of the light chains, and then they determined that if the ratio was at least 100, that would put the patient at a very high risk of progression, and it would happen within the first 2 years. Again, Kastridis contributed from his Greek study, and he found that in 7% of the patients there was a ratio above 100, and they also progressed, in this case, within 18 months. And in fact, there was also a third study that was carried out here in the United States by Waxman et al., where the light chain ratio of 100 progressed within 2 years and at 64%. So in this case, there are 3 studies. So the International Myeloma Group, Working Group concluded with 2 or more studies independent of each other showing the same thing. This is time to be integrated in the criteria for multiple myeloma requiring therapy. The third new criteria originates from studies done in Heidelberg in Germany, and is based on modern imaging, more specifically so magnetic resonance imaging, or MRI, and they show patients who had more than one, so now we're talking about 2 or more, focal processes in the bone marrow, those patients, or in the bone, they would be defined as having multiple myeloma requiring therapy. And the first study that was carried out was published in 2010 by Dr. Jens Hillengas and his colleagues from Heidelberg, and they studied 149 patients with smoldering myeloma, and they conducted whole body MRI, and they found that there were focal lesions in 28% of the patients. And when they started counting these focal lesions, they saw that in 15% of the patients, so these were 23 out of the 149, there was more than one focal lesion. And then when they looked at the patient's risk of developing multiple myeloma, they saw that these individuals who had more than one, so there were 2 or 3 or more, they had a hazard ratio of 4.05, which was highly significant. The median time to progression for these patients was 13 months, and 70% had progressed within 2 years. They also did multivariate analysis, and they also applied PET-CT in this series, but the findings were based on MRI for this particular finding. Again, the Greeks were able to reproduce the findings, and Kastridis et al. Took his series with 65 patients, and they did spinal MRI. So they did not do whole body MRI, but they focused on the spine, and they show with a minimum follow-up of 2.5 years that 9 patients had more than one focal lesion, and the median time to progression in this series was 15 months. At 2 years, 69% of the patients had progressed, and if you look another year out, 3 years out, it was 85%. So again, the International Myeloma Working Group concluded that with 2 more studies showing the same thing, let's include this as one of the new criteria. The risk of progression to myeloma or AL amyloidosis is also associated with elevated light chains, and this is further information from the Greek study. There is a third study of patients with involved to uninvolved also that was carried out by Worksman. Well, actually, sorry, this slide is not correct. This slide should go. This actually relates to the light chains. This was a mistake. I apologize for that. So please ignore this slide. We should go to the next slide. So there were only 2 studies for MRI. So there were 2 studies that show the link between focal processes and progression to myeloma. So to repeat what I told you, we have the bone marrow, 60% plasma cell infiltration. Number 2, you have the serum-free light chain. And number 3, you have these imaging findings. So these are patients that may not feel sick, but they probably are currently told that they have smoldering myeloma, and if they have not been worked up, they may not know that they now fulfill the criteria for multiple myeloma. There are also additional edits in the old criteria. I'm going to go over that also as part of this presentation. So for hypercalcemia, there is no change. It's defined as the serum calcium of greater than 0.25 millimolar per liter, or more than 1 milligram per deciliter, higher than the upper limit or normal, or if we were to enforce a cutoff, it's greater than 2.75 millimolar per liter, or more than 11 milligrams per deciliter. And this is unchanged from the previous version from 2003. For the renal failure, in the 2003 criteria, renal failure was only defined by the serum creatinine concentration, and it was defined as 173 micromolar per liter, which is roughly more than 2 milligrams per deciliter. That's attributable to myeloma. So here is a little bit of a circular evidence. If it's attributable to myeloma, then it's considered to be part of the CRAB criteria, and the patient has myeloma requiring therapy. So, of course, if you don't believe it's attributable to myeloma, then the patient doesn't have myeloma, versus if you do, then the patient has. The reason it's written like this is because, of course, of patients that could have kidney failure due to other reasons. They could have diabetes, hypertension, or there could be other completely different diseases. And that could also be, for example, AL amyloidosis, involving the kidney. So the clinician has to use the clinical judgment here in this particular case. But the point I'm trying to make when I'm talking about the change from the creatinine to the new version of 2014 is that creatinine, as we all know, is not a reliable measure to determine the kidney function. As we get older, the creatinine can go up. So instead, what the new version includes is the estimation of the glomerular filtration rate, the GFR. And the criteria specifically state that one can use the MDRD or the newer, the chronic kidney disease epidemiology collaboration, or the CKD-EPI formula. And I personally think that the CKD-EPI formula is the best one, and this is what most nephrologists would use in these days. So the criteria says if these 2 measures provide a GFR that's less than 40 milliliter per minute, which corresponds with a 40% decrease from the lower limit of the normal GFR, that would now be the R criteria in the CRAB being fulfilled, and the patient now has multiple myeloma requiring therapy. So this is an update from the previous version. That's also important. For anemia, there is no change compared to before. The hemoglobin value of more than 20 grams per liter below the lower limit of normal, or a fixed cutoff, if the hemoglobin is less than 100 grams per liter or 10 grams per deciliter, that patient now has multiple myeloma requiring therapy. Again, of course, one has to use clinical judgment. If the patient has a bleeding, if the patient has ulcer, if the patient has hemolysis, if the patient has any other reason for having anemia, then the patient does not have myeloma requiring therapy. But if all those things have been ruled out, this is the same as the 2003 criteria in this 2014 version. Let's look at the bone lesions. Here are important updates as well. And the criteria from 2014 state that traditionally bone disease was identified on the basis of conventional skeletal radiography or skeletal survey. And they further state that although the 2003 criteria did not explicitly state that MRI and PET-CT can be used to fulfill the CRAB criteria, it was the intent of the investigators who wrote that version that those findings also should be considered to be equal to yes, positive lytic bone lesions. So in plain text, this paper says that if you do skeletal survey, you do PET-CT, you do CT, or you do MRI, if you pick up lytic lesions with either or multiple of those modalities, that counts. And I think this is very important because, as we all know, with these newer technologies, the detection rate of bone lesions go up drastically. And as stated here, newer imaging technique has greater sensitivity than radiographic bone survey for detection of myeloma lesions, with as many as 80% or more lesions detected by new techniques. So I think in particular the CT is very powerful. So what does the guideline recommend? So the guideline recommend that one of PET-CT, low-dose body CT or MRI of the whole body or spine should be done in patients who have a suspected smoldering myeloma diagnosis with the imaging modality, the exact imaging modality determined by availability. So what does this mean? It means that when these guidelines were written, there were people from around the world that participated, and people from the United States wanted to emphasize the use of PET-CT and MRI for patients with smoldering and also for newly diagnosed. But because all these modalities are not available everywhere, the language is such that for smoldering patients, in order to rule out what I reported in the beginning here for one of the new criteria for focal processes by MRI, therefore MRI is recommended for smoldering. And if one can do it for the smoldering with PET-CT also, that would detect earlier lesions. I can tell you in my practice, we would do PET-CT and MRI for all smoldering and for all newly diagnosed patients. And that would still be covered by these guidelines. And I do project in the new version of these criteria that we're probably going to move into recommending PET-CT. But as it's written right now, still to do a conventional skeletal survey is in line with the 2014 guidelines. And this is simply because they are international guidelines. The skeletal survey versus the CT, there is probably up to 60 or 80% higher detection rate with the CT, even in a PET-CT setting. So you will be much more likely to find early lesions. They also clarify in this 2014 criteria that the size of the lesions has to be 5 or more millimeters in diameter seen on CT. So if it's smaller than that, then it does not count. Also, it says that if there is an uptake in the SUV, if it's elevated, that is not adequate to set the diagnosis. You have to see it also on the CT components. And that actually addresses a very important aspect. If you have 100 patients with multiple myeloma who have a lot of bone disease, if you do PET-CT, the CT component of that PET-CT will see all those lesions. The PET is not going to be positive in every patient. It's actually commonly going to be negative. Maybe 40% are going to be negative. And that is simply because the FDG tracer that we are using as the standard tracer in PET-CT, we use across diseases, that is not very appropriate for myeloma. Myeloma does not have a high proliferation rate on average, so it very likely falls negative. So having high SUV could be due to inflammation. It could be due to myeloma. So go back and look for the CT. So if there is CT abnormality and there is SUV uptake and that looks like a lytic lesion, yes, that counts. If there is SUV in the absence of CT, that does not count. If there is CT abnormality but there is no SUV uptake, there is still a lesion in this setting. So in the third paragraph here, it says that care should be taken to avoid overinterpretation or to overcall these lucencies that you can see with these modalities. And if you're not sure, it may be better to repeat the study in a few months and make a decision based on that. We don't want to overcall these things. And this is, of course, clinically very challenging. If you run a private practice and you send patients and you get a written report and you don't have access to the imaging, that could be difficult. But I think it's very important for the patient. So reaching out to radiology and discuss these findings and make decisions based on a conversation is absolutely in the best interest of the patient. So to summarize this presentation and conclude, here is a single slide summarizing the new definition of multiple myeloma. You have the myeloma defining events, evidence of end organ damage that can be attributed to the underlying plasma cell proliferation disorder, specifically either the CRAB criteria, which is hypercalcemia as defined on the previous slides, renal insufficiency as defined either by creatinine or creatinine clearance. And I would really emphasize that using the CDK epi for clearance is way to go. Anemia, same as before, and bone lesions. And it is okay to do a skeletal survey, but a CT or PET-CT, and the reason PET-CT is probably better than CT is that the PET-CT has lower radiation because it has lower resolution than the conventional diagnostic CT. And if one is to image the whole body, using the low-dose CT that comes with the PET-CT gives a better detection than the skeletal survey, but has lower radiation than the CT, and probably not a whole lot different in detection between CT and PET-CT when it comes to the CT component. So I think PET-CT is way to go in the future, but skeletal survey is also supported by the guidelines. And again, to re-emphasize the new defined myeloma-related events here, if the plasma cell percentage with clonal plasma cells is 60% or higher, now the patient has multiple myeloma requiring therapy. If the ratio involved to uninvolved is greater than 100, and the involved one, and the involved means the one that's elevated, has to be 10 milligrams per deciliter or higher, or 100 milligrams per liter or higher. Again, the patient, based on this blood test, has multiple myeloma requiring therapy, even if the CRAB criteria are not there. And lastly, if the MRI, and if one has access to whole body MRI, that would be preferable. If one only has access to spinal MRI, that has a pretty good detection rate, and the number of missed cases compared to whole body is low based on available data. If MRI is exercised and there are two or more, so more than one, focal lesions of the bone or the bone marrow or both, that patient now has multiple myeloma requiring therapy. And I would like to do a few more remarks here. In the 2003 criteria, there were a couple of non-CRAB and organ damaged criteria that were mentioned, and there were also additional revisions that came out afterwards as some kind of addendums. And specifically, they included hyperviscosity, they included AL amyloidosis, and also they talked about recurrent bacterial infections. And in these subsequent versions and addendums, there was language saying that if a patient did not have CRAB criteria but had these types of criteria, that would be myeloma. But in the new 2014 criteria, it's clearly stated that over the years, the CRAB features have been regarded as the myeloma-defining events. And it clearly says that all of these other factors or criteria have become less important with the inclusion of new non-CRAB biomarkers, which is part of this 2014 paper. And therefore, the International Myeloma Working Group do not recommend the use of these the infection or amyloidosis or hyperviscosity. They do not recommend the use for initiation of treatment based on these factors. They are no longer part of the criteria. Also, now I'm reaching the end of my presentation. I have only 2 more slides left after I'm done with this one. It also states, and I think this is important when we communicate with each other, we have to stick to the language. The term multiple myeloma is preferred instead of using symptomatic multiple myeloma. Symptomatic multiple myeloma is a metastatic disease state where we do not want to go anymore. So we talk about multiple myeloma, and that's clearly stated in this paper, and that's what these biomarkers will do. So no more symptomatic multiple myeloma. It's multiple myeloma that is in the guideline. Also, in the very end of the paper, and this is my second last slide, it says that very likely additional biomarkers with the same or better performance characteristics than the ones that were now included in this updated definition, they will probably be identified with ongoing research. There are a lot of markers that have been and that are currently being evaluated, but the reason that they, at this point, were not included in this version is simply because they were only found by one study. So when we had these discussions at the International Myeloma Working Group, when we decided which one to include, we set the criteria to having 2 or more independent studies showing the same thing. So if there are only one study, that is pending. We need another study for replication. If we can replicate it, that's most likely going to become a new criteria. And we will have the same bar in terms of what we require to see in terms of time of progression. It probably has to be progression within a year or 2 in order to fit in here and be in line with these other markers we included in this version. And lastly, I think this is very important. This is now the implication of what we are talking about. This paper came out this week in JAMA Oncology by Sigurdardottir et al. And I have been involved also as a collaborator with this study. This is a study that was carried out in Scandinavia with more than 15,000 patients that were diagnosed with myeloma between the mid-70s up to around the 2000s. And there was linkage between all these patients that includes the entire population of Sweden and all patients diagnosed with myeloma during this time span. And it was linked with a nationwide MGUS cohort. So it was able to look to see if patients were diagnosed with MGUS and followed over time and developed myeloma versus if they just presented with myeloma up front. And there is about a 15% overall survival in this study. And of course, because the study includes patients from the 70s and onwards, the overall survival in the study is in the range of about 3 years if you include all those older cases. But if you start zooming in on the more recent time periods, you see that survival goes up. But still, there is a major discrepancy in survival. And in fact, the discrepancy between patients that were followed versus not followed in the era of novel drugs, that seems to be even wider. Also, this was replicated in another study that came out also in March of this year by Go et al. In Clinical Lymphoma Myeloma Leukemia Journal, showing very similar findings in the United States using the Serum Medicare study. that includes people above the age of 65, and is a linkage between SEER and Medicare. And they show very similar findings, and also in this study, they show that the early detection, which was through follow-up for these MGUS, when the patients developed myeloma, they had less severe complications. They had less kidney failure. They had less need for dialysis. They had less fractures. They had less spinal cord compression. So being diagnosed earlier, I think is very important, and that's exactly what these International Myeloma Working Group criteria are going to deliver. So I do think that we're going to see a much better overall survival for myeloma worldwide in the coming years, and I'm very, very excited about that. And with that, I would like to thank you for your attention. I'm happy to take any questions you may have.
Thank you for that informative presentation. Before we get started on the question and answer session, I'd like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. And our first question is, have there been any studies on patients with involved/uninvolved FLC greater than 100, but involved FLC less than 10 milligrams per deciliter?
Yes. So that was part of the examination that the Mayo Clinic did. And basically what they show is that if you enforce this rule that the involved has to be greater than 10 milligrams per deciliter, you have better specificity of detecting who is going to progress. You lose a little bit of the sensitivity, but in practical terms, it means that you do less over-treatment of patients. So the thinking was if you follow patients a little bit longer, then they would meet the criteria. So it's basically a way to try to reduce the risk of over-treatment. So this is true, as you probably are aware, for any lab test we have, for anything in the lab, where is the right cutoff? And you run the risk of sensitivity or specificity issues, and that's how the Mayo came up with it. And it's in their paper. You can look it up in detail in their paper.
Okay, next, are treatment options for multiple myeloma disease dependent upon how many of the criteria a patient presents?
If the criteria, if you need to have one or more, is that the question?
Well, they say, are treatment options for multiple myeloma disease dependent upon how many of the criteria a patient presents?
So the treatment options are not implicated by these findings. So these criteria mean that the patient has multiple myeloma requiring treatment. And after that decision has been made, it's another question which therapy needs to be used. And that includes a lot of other factors that is not part of it. So this is yes, no, need therapy or don't need therapy.
Okay. Is the use of contrast recommended with a WB MRI?
In these studies that were done, there is no contrast included. These are whole body MRIs. There are very many different protocols for MRI. Diffusion weighted imaging, which is one of the protocols, is something that the German group has been working on, but there is no contrast involved in these. I do think in the future that there probably will be whole body PET MRI. There are very few machines available in the world right now. And I think talking and thinking about how we image myeloma, I do think that for all these years we have kind of almost imaged the wrong organ system. And the reason I say that is because multiple myeloma, as we all know, is the disease of the bone marrow. It's a plasma cell disease. When we send the patient for a skeletal survey, we image the bone. The bone surrounds the bone marrow, so basically we are only imaging a complication of what's going on in the bone marrow. So if we increase the sensitivity of bone disease with better technologies, such as CT, we are better to detect complications. Why are we imaging complications? So the best modality to use for imaging soft tissue is MRI. It's not CT, and for sure not skeletal survey. CT can be partly used for soft tissue, but MRI is way better. We would use MRI for the brain for a patient if we're looking for some structural damage in the brain. So imaging the marrow, MRI is much better. The problem then is that we don't really have good tracers to image the plasma cells. The FDG PET-CT I mentioned is a generic tracer, the FDG. So I think in the near future we will have tracers that are much more myeloma specific, and they can probably be loaded in the MRI machine, and then we can start imaging myeloma and pick it up very early. But this is the future.
Okay, next. So just to clarify, if the biomarkers are above the guideline levels, I should treat the patient even if they do not show end organ damage?
That is correct. A patient that has either one or more of the CRAB criteria, or if the patient has any of these myeloma-related events. There are 7 factors. If one or more of these are present, the patient has multiple myeloma requiring therapy. So we are away from the old symptomatic myeloma. This is multiple myeloma requiring therapy. Of course, it's a judgment call. If the patient is very reluctant to it, of course, I guess that will be a discussion. But I think in the future, as we see how this impacts survival, I think more and more patients are going to realize that this is the way to go. And this is how we treat other cancers. Breast cancer, for example, if you find a very early stage disease, you would treat that. Prostate cancer, same thing. Any other cancer, myeloma is now taking the same approach. And I think this is totally driven by the access to new drugs that are very effective and much less toxic. There are multiple studies showing that early treatment with these new drugs can majorly prolong survival. In America, we have an overall survival for myeloma for the younger patients that is on average longer than 10 years. 10-year overall survival on average for younger patients. If you look before the turn of the century, it was 3 years. I project it's going to go up another 5-10 years soon.
Okay, current treatment options are dependent upon M protein relapse. With the new guidelines, how will this change?
Can you kindly repeat that question?
Sure. Current treatment options are dependent upon M protein relapse. With the new guidelines, how will this change?
These guidelines only determine that the patient has multiple myeloma. So if the patient has an M spike of whatever number it is, and none of these criteria are present, then it's a matter of if the patient has MGUS or smoldering myeloma based on the workup. If one of these or more of these criteria are fulfilled, now the patient has multiple myeloma. And the therapy would be given the same way as it would have been given in the old setting with the old criteria. Monitoring would still be based on the response criteria the same way. So if the patient has an M spike, that would be focused on the M spike. If it's light chain disease, that would be focused on the light chain disease. And for non-secretory disease, that would be focused on that. And if there is extramedullary disease, that would be focused on that. So none of those things have been changed in this setting. This is only for when to initiate therapy.
Okay, the next question has a couple of parts, so I'll read it all at first, and then let me know if you need me to reread. So if you catch myeloma earlier with an accurate assessment of free light chains, what are the therapeutic interventions and options, and do patients truly benefit from early diagnosis? In other words, does early treatment lead to cure, better quality of life, or better prognosis, increased OS?
So you're asking me if there is evidence that these new criteria will actually make a difference. So of course, it will take some time to have the data to fully be able to evaluate it. But I showed you these 2 studies that was published this week, one in JAMA Oncology and one in clinical lymphoma, myeloma, and leukemia, showing that patients that were followed for early disease for MGUS and progressed to myeloma, that there is a 15% better overall survival. And I think it's very reasonable to believe that patients that are being treated earlier are going to be very similar to those patients. And keep in mind that the drugs that were used on these studies, they are drugs that were around for 20 years. So we don't have the data mature at this point, but based on extrapolations from these 2 publications, there is suggestion that overall survival maybe could be 20 or 25% better in the setting of newer drugs if the therapy starts earlier. But in order to have the strong, solid data, we need to collect prospectively this information, and that needs to be done.
Okay. What tumor markers are currently being used in your studies, and do you think that CKD epi formula is better than MDRD? If yes, why?
What tumor markers are used? So I assume that refers to detection of the biopsy, and how to work up the biopsy under the microscope and to do the flow. So that would, of course, be the standard for bone marrow, to do CD138 and to do kappa lambda staining to look for plasma cells and to look for light chain restriction. And the flow, for the purpose of setting the diagnosis, that would be the gating of 38 and 138, and also for light chain restriction for kappa and lambda. But also, of course, there are a lot of other markers that go into that, and there's a whole list of that. So, for example, CD56 is probably present in around 80% of myelomas. That's typically an abnormal plasma cell versus normal plasma cell marker. And also, you can do CD20, which is probably present in maybe 10 or so %. That could be associated with extramedullary disease. There is CD45, and there is, I mentioned 38 also, et cetera, et cetera. There are very many markers that can be used for the purpose of defining the characteristics of the cells, but that probably goes more in the direction of more research. So number of cells, 38 or 138, and light chain restriction would set the diagnosis. And this is, of course, common information in the laboratory. When it comes to the formula for estimating the kidney function, you have the MDRD, you have the old Cockcroft Gold, and then you have the CDK Epi. And these are not myeloma-driven projects. These are projects that have been developed by kidney doctors. And in the nephrology community, I think that there is strong consensus that the CDK Epi is the most reliable method, and the reason they have concluded that is because if you take an older person who is not as tall, and also females, I think, are being negatively, they have a negative impact by, if you try to estimate a GFR, it's going to be falsely too low. So an old, short woman would be false low with Cockcroft Gold and also MDRD, and the CDK Epi would be more correct. I tell you a funny side note here. I'm sitting here in the hospital at Memorial Sloan Kettering, and next door to me is the head of the kidney service for the hospital here. And he has done a very good job convincing me that CDK Epi is the best method. We have gone over a lot of data from patients. So I think it simply comes from the fact that it's a more reliable method.
Okay. And we have time for one more question. For those who have lost a parent or family member due to multiple myeloma, do you recommend and what annual lab testing should be performed to monitor possible hereditary MM?
That's a very difficult question. So at this very moment, there are no written formal guidelines suggesting that patients should be screened. There is no such document. In that paper, the JAMA Oncology paper that came out this week, that has gotten a lot of media attention, it actually states, and I was one of the co-authors of this paper, we state that maybe for individuals that could be potentially at a higher risk of having a plasma cell dyscrasia, that could be a reason to consider that. But we didn't say in that paper that this has to be the guideline. We were addressing it. I think it's likely in the coming years that the guidelines could change, and that the guidelines could say that for individuals who have a family member, if they undergo testing, that you could capture that, and that could lead to earlier diagnosis in the event that there is progression. And there are studies, and we have done studies in Scandinavia several years ago showing that there is a little bit of a higher risk in family members. And to put that in numbers, the relative risk is about twofold higher, but the absolute risk is not very high. So the percentage of people with MGUS is around 2% above the age of 50 in the population. So having a family member, that means that the risk is maybe in the range of around 4% or so. Now, if one wants to know, the only way of doing it would be to do the blood test and see if there is evidence. So I think it's still something that's not clear, and I spend a lot of time talking to family members, and different people want different things, and I try to do it on a case-by-case basis. So that's the best answer I can give you.
Thank you, Dr. Landgren. I would like to thank our sponsor, Binding Site, for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through September 10th, 2015. You can also find a copy of the presentation to be used as a resource by clicking on the File button at bottom left. You'll receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. See you next time. Goodbye.
Bye. Thank you very much.